Well, good evening. My name is Dr. Tim Lubenow, and I'm Vice President of the Fellowship Education Committee. And tonight is the first in our series of webinars for the Aspen organization, specifically for the Young Innovators and Fellows Committee. And generally, this is a venue where we have fellows train other fellows. Tonight, we have some exciting, experienced panelists who are going to broach a subject that we haven't really talked about before, and that is to review and point out some of the different career pathways that one has as a fellow about to enter practice, and then also to understand some of the practical aspects involved with the nuts and bolts of salaries and contract negotiation. Joining me is my friend and colleague, Dr. Daniel Pak. Dan, please introduce yourself and our panelists for tonight.
Thanks, Dr. Lubenow. As you mentioned, my name is Dan Pak, and I'm on faculty at the University of Texas in Houston. And I hope that you guys all find this particular lecture very helpful, because these are all the things that they don't necessarily teach you during your training, even as you go through your fellowship year. So today I have really the great pleasure of having two very esteemed panelists who have a lot of expertise in this particular arena. We have Dr. Jay Grider, who many of you might know and really needs no introduction, but is full professor at the University of Kentucky, also serves as the CEO of Kentucky Medical Services and the Chief Physician Executive of UK Health. We also have Tina Ravenbark, who is president and CEO of Advanced Practice Solutions, where she's helped countless physicians nationally start and expand their practices, open ASCs, and help people with operational optimization, among other things. So we have a really exciting lecture today. I'm looking forward to what our panelists have to say. So with that said, I'm happy to hand over the reins to Tina, who will talk about the types of practices you might consider and how to negotiate your contracts. So Tina, hand it over to you.
Thank you so much, Dr. Pak. I appreciate the opportunity to be here and to be surrounded with these esteemed colleagues and to have a moment to speak to you as you have started fellowship and have these contracts and negotiations on your mind. So not to waste any more time, a couple of things that I think can help you be very well positioned as you begin to explore the opportunities that are presented to you. First of all, you need to know what you want and how to ask for it. So understanding, doing some self-reflection on what's your primary goal. Do you want a situation where you have some continued mentorship as you are transitioning from academia into private practice? Is financial compensation at the top of your list? Are you more looking and hoping that your first opportunity will be a long-term engagement and where you kind of land for the long haul? Are you primarily interested in the equity building, perhaps in the practice, perhaps in the real estate in which the practice is operating, perhaps in a potential ASC or ancillaries that are associated with the practice? Making sure that you understand your family status and how that impacts the goals for this first opportunity post-fellowship, and what you are looking for 5, 10, 15 years down the road. Next slide, please. So as you begin to think about this and talk about this with your family, partners, spouses, whomever, how would you highlight this? How would you rank these opportunities? Are there even non-monetary benefits that you would like to consider as far as quality of life, scheduling, the length of your day, etc.? Next slide, please. So I'm going to speak to a few of the practice types that you will encounter as you're exploring opportunities presented. So the first would be the employed physician in a hospital practice. So hospital hires a physician generally in a hospital outpatient department. There's also the private practice employed physician. So that can even vary within that to be the single specialty or just an interventional pain practice where all the providers, all the physicians are pain physicians, or more frequently in recent years, we've seen an expansion of pain positions within non-pain practices. So large ortho groups recruiting and hiring pain physicians, neurospine groups recruiting and hiring pain physicians, and multi-specialty surgery groups even recruiting and hiring pain physicians. Next slide, please. So I've dropped this grid in for your future reference as you begin to walk this path and understand the opportunities and options, just as a kind of a sliding scale to figure out how the varying organizational types and positions will impact your day-to-day work life and your long-term goals and your ability to impact change within the environment that you're working. Next slide, please. So after you begin to understand what you want, what you think you want, what's going to be the most desirable situation for you, your family, your partner, your spouse, your children, if you have children, then first step is to know the market that you're entertaining. What's your worth in this market? Because the starting salary for a pain physician in a rural market may be actually much different and sometimes even much higher from a recruiting perspective than the starting salary for a pain physician who was training at Cornell and wants to remain in Manhattan. Competition is higher. The demand may be higher in the more underserved markets, those types of things. What's your worth in this particular scenario and practice type? And I think Dr. Greider will speak a little bit more to this and how the resources available for your compensation package will vary in an HOPD versus a private practice model. Any practice related specifics that will impact your worth. For example, is it a surgical practice? Are you the first or second pain physician in, for example, a large ortho group? What is it that your function will be? Why are they recruiting you to an ortho group? Is it because they would like for you to be available to perform diagnostic and therapeutic injections to clear a patient for surgery or to help define levels of a spine surgery? Is it because they want you to be readily available to do ablations when a successful surgery happens, yet a patient's still symptomatic? Is that going to impact the ability for you to use your full skill set that you've worked so hard and trained for in fellowship? Those are things to consider because it's actually reality when you are looking at these types of opportunities. Also, what's the market profile of the opportunity that you're considering? So, for example, if you're going to be moving into and taking a position in an area that the average age is 35 to 45, the demand for our interventional pain services are not as prevalent in that age range as they would be if it was a retirement community where 40% of the population in the area was over the age of 65. What's the average household income in the area? Because that leads to and impacts the patient's ability to pay the bills. It can impact the patient's insurance status. It can impact the kind of coverage that they have, which all plays into the compensation package that practice can ultimately offer you. Poverty levels similarly in the area obviously have an impact on that, because then you're talking about the percentage of Medicaid as your payer mix, the percentage of uninsured patients altogether, which they don't, their ability to pay or their insurance status doesn't change their need, but it does change your ability to get paid and compensated for the services that you provide. Next slide, please. knowing and understanding the opportunity, and again, as I made reference to, know your role. So for example, if you're interviewing for a position in a private practice or an HAPD, are you filling a vacancy? Is this a new role, or was there someone there before? If there was someone that held that position before, what was the cause of their departure? Was it a retirement, an illness, forced relocation because of some family situation, or something else? It's very important understanding this to inquire and ask permission to, or ask contact information to speak to the person that held the prior position. If this is not an existing position, why the expansion? Is there a growth pattern? You know, the area is growing, the population in the area is growing, the insured population in the area is growing, perhaps there's a new employer in the area. Why is there surplus demand now? And as an example, you would also want to know, if there's surplus demand now, what's going to be offered or provided to help you get from the existing surplus demand to the level of patient volume that you will need to create a reasonable situation, a reasonable patient schedule to support the income that you're seeking. So for example, if Dr. Greider was practicing and he says, gee, I'm seeing 50 patients a day, but really I'm more interested in seeing 40 patients a day. That's really a more tolerable schedule for me. So I've got a 25% surplus capacity. So I need to begin to look at hiring another associate. And Dr. Pak applies for this position and says, this is great. I'm walking into a stocked pond where I've already got 25% of my patient schedule already available to me. Well, that's fantastic, except that what Dr. Pak can't live off of 25% of a salary, and Dr. Greider can't pay Dr. Pak 100% of a salary if he's only seeing 25% of the patient volume, not in a sustained effort anyway. So what's going to be committed by the practice in the way of financial resources, staffing, whatever, to be able to help expand that and continue to grow the volume. Okay. So also know your audience. Read the room. So what am I talking about here? Is this a practice that you would be the first associate hire? If that's the case, perhaps the position that you're talking to is the founding position. They started the practice from scratch. They wore all the hats initially when they didn't have the resources to employ an office manager or a expanded staff or x-ray tech or whatever. You know, they invested all the blood, sweat, and tears to get the practice to this point, and here you are coming in and you're going to be the first person that they hire as an additional physician provider. Conversations with this founding position around the expansion of the practice, and then kind of sharing with you their baby that they had and nurtured and brought to this point, are a little bit different than if you are applying and having contract negotiations with someone who's like a Dr. Deere, who has recruited, hired, and mentored and employed many successful physicians who've gone off to do their own thing or whatever. So you're talking about two different audiences there, and the conversation needs to be a little bit different, a little more sensitive to the questions that are asked and the focus of how they are delivered. Next slide, please. Short-term considerations as you're evaluating your offer. Obviously salary, obviously benefits. Is there intrinsic value that needs to be considered? Perhaps training opportunities or clinical trial opportunities or some sort of affiliation opportunity. with other organizations that can enhance your professional growth, or just overall improve your working environment. Potential future enhancements to also be considered, but these are a little bit trickier because you're going to want some sort of clearly defined evaluation. So for example, if I am joining a practice and I want to know if I'm ever going to have the opportunity to buy into the practice, as I mentioned earlier, if this is Dr. Greider's practice and he's built it from the ground up with all of his blood, sweat, and tears, being sensitive to that as I ask the questions about my ability to buy into the practice is super important. Maybe I don't have to have a specific date in the future that says, as long as I continue to breathe and work and be reasonably successful, I can buy into this practice on January 1st of 2028. Perhaps instead you say, if I am Dr. Greider, what does success in this role look like for you? What kinds of things would I be doing? What kinds of goals would I be meeting? What kinds of metrics would I be meeting for you to consider me a successful physician associate? And how are we going to evaluate that? And can we decide that we're going to perhaps have a sit down on a quarterly basis, or we're going to have a sit down on a semi-annual basis? So it's, as you can see, that's more of a, let's make a plan for what that looks like instead of a set in stone, black and white, which may not be comfortable for the physician owner. Long-term considerations. So potential future enhancements. Again, you want clearly defined evaluations here. What is your opportunity to buy into the practice itself, to buy into the real estate associated with the practice, or any ancillaries and ASC options, and what would be the evaluation criteria for each. Next slide, please. Key points to evaluate: legal implications of the actual contractual document, obviously, are clearly important. A financial evaluation, I think, is almost at least equally important. Having someone take a look at not just the compensation today, but the value of the compensation and the opportunities in the long term is super helpful and can better help you compare opportunities that may not look exactly the same on day one. Next slide, please. In a lot of situations, I advocate for doctors to do doctors' work. You're spending a lot of time wrapping up your educational journey, and you've got a lot of financial investment in that. You've got a lot of blood, sweat, and tears into your own training here, and family situations, and the whole 9 yards. So don't try to be an attorney. Don't try to be a financial planner. Feel free to reach out to me if you have questions about opportunities as they compare to what else is floating around in the area. But people like a Justin Harvey to evaluate the financial parts, very astute healthcare attorney, those things are worth your investments to make sure you get what you're planning for. Also, some of the very best compensation packages and contracts and negotiations that I've seen have come where the applicant is willing to bet on themselves. How do you do that? Well, so you need to have a clear understanding of the overhead, the compensation computation. If it's based on direct costs, how are those evaluated? If it's based on RVUs, how are those evaluated? And then also understanding your ability, your skill set, and how your proficiency will impact your ability to produce. Next slide, please. Additionally, so if you have a really good sense of, hey, I can see this amount of patients a day, hey, I understand that if I see X amount of patients per day or produce X amount of RVUs, I'm going to be compensated in this manner. There are also operational processes that can impact your ability to be successful. So how's the facility laid out? Are you going to have enough staff support to see 25 or 30 patients a day? Will you have access to additional equipment should you get busy enough to need an additional procedure added to the practice? How about the EMR? Is the EMR laid out or a reasonable, feasible working situation for a pain practice? And then last but not least are the revenue cycle processes. Is the front desk in that group good at collecting co-pays? Are they able to get claims out and get paid? Are the billing processes slick so that the practice is able to collect the money? Okay. And then obviously then the environmental, the population and income, the payer mix, the eligibility, collections, prior authorizations is unfortunately a huge impact on our practice success these days, and then the billing proficiencies as well. And then the small stuff that is never small. So perhaps the most important points that are rarely discussed and the things that we forget to ask about until the end or until it's too late are reputation management. What's the practice's reputation in the area? Is that going to be helpful or hurtful as you're trying to obtain new referral sources? Are there any medical board actions? Have there been any serious adverse events that impact medical malpractice for the practice? Any hospital privileges incidents that will impact you adversely that you may not be aware of? Any CMS, OIG, Department of Health and Human Services implications? So has the practice ever been audited and had an unsuccessful audit? And then any DEA concerns? Have there ever been any issues with prescribing practices? Next slide, please. So how do you go about, as you're considering these offers, you're looking at postings online, you're hearing about these opportunities through perhaps your fellowship. How do you get all this information? Well, obviously, again, prior providers that worked in that practice, if you can speak to those are golden. Medical board searches, OIG, CMS, DOJ website searches, hospital med staff searches, industry reps, and then other industry contacts. So ask your attendings, ask folks at meetings, all those folks have just a wealth of information that are maybe otherwise hard to obtain. So we're going to hold the questions now, and I am pleased and excited to introduce and turn this over to Dr. Jay Grider.
Thank you, Tina. You can go ahead and put my first slide up. So imagine if you were in a scenario where somebody said to you, you have to find a partner and get married on June 30th of next year. And so what would you do? You'd look around, you would try to find the best person you could possibly find. You would never expect that you were going to find true love in that first scenario. You would just do the best you could. And that's the scenario that each of you are in. Good jobs come available throughout the course of a year. And people hear about good jobs through their network and all sorts of different things. It's really a very artificial scenario that you're engaging in, which is you have to have a job on July 1st of next year, and you're going to take the best one that you have around there. So take some of the pressure off of yourself. Give yourself some latitude to say, you know what, I probably am not going to find a perfect match right off the bat. Here, I'm going to do the best that I can. I'm going to try to get in the area that I like the best. But if you take that mindset that I wouldn't expect to find the perfect thing under this time crunch, know that it will come along. And once you get 2 or 3 years under your belt, you even right now don't even know how you're going to practice exactly. So understanding who you will be in 2 or 3 years and then matching a practice environment to it. If it's the one that you're in, that's great. If there's one that you know about and you begin to learn about, even better. So let's just take some of the pressure off right up the bat. Next slide. So as we're talking about this, it's important to just get an understanding of how physicians get paid in this country. So it's an interesting journey. Prior to 1965, physicians, there was a little bit of medical insurance that had been started during World War II, but largely physicians were paid based off of what people in their community could pay. And physicians were largely middle-class individuals with their incomes matching those of their communities, because they couldn't charge more than people in their communities were able to pay, because it just wouldn't work. And like many things, such as education, whenever the government got involved in paying for a certain product and you dissociate the cost of that product from the person who's actually purchasing the service and the person providing the service, and you have this government middleman, actually costs started to go out of control. CMS created Medicare and Medicaid in 1965. And physicians fought it because they said it would be the end of practice. And it's actually what has fueled the government resources that came to bear, is what fueled the rise in incomes in physicians across the country. And here's how that happened. You were paid on a usual and customary charge. So if you took out a gallbladder and you said, well, I think I should be paid $110 for that, and they would just pay it, a usual and customary charge. A guy down the street might charge $120. They would just pay that. And so eventually you began to look around and go, 170, pay it. 210, pay it. Well, sure enough, within 10 to 15 years, prices were starting to move out of control. It actually took a long time because physicians were very conservative and did not overcharge at first, but eventually they began to realize, hey, I can charge whatever I want to. And in the 80s, they started to impose what's called a relative value scale. Let me explain that. So if sitting in a primary care office dealing with established patients with blood pressure issues is the least complex thing in medicine, it's given a value of 1, a relative value of 1, a unitless, valueless number that is just a comparison, kind of like morphine is 1 on the conversion scale of other opiates. Then a skull-based surgery where they operated for 12 hours would be 72 times as complex as sitting in the office dealing with that person's blood pressure for 15 minutes. So that had an RVU value of 72. So everything was somewhere between 1 and that most complex surgical procedure out there, and everything else is given this arbitrary number. Well, I think that's about a 1.5, or I think that's about a 2.5. So how do they negotiate that? Well, actually, there's a group called the RUC that gets into a room 4 times a year, and physician groups from orthopedics and neurosurgery and pediatrics and family medicine and anesthesiology and all the specialties argue and debate over the relative value complexity over tenths of an amount of an RVU, because tenths of an amount result in hundreds to millions of dollars in payments in specialties. Because the sustainable growth rate, which was put in place in the Clinton era, says we're going to pay $3 billion to physician practices. That number's not exactly right, but just go with me here. $3 billion, and you physicians divide it up amongst yourselves. So every year we get into a room and they negotiate. Cardiology is going to get a 0.17% raise, but PM&R is going to take a 0.2% decrease, and rheumatology is going to go up and pulmonology is going to go down, and so it's always just this, but it's a fixed pie that's out there. Next slide, please. So the RVU is made up of 3 components. It's made up of physician work, practice expense, and malpractice expense. That's the physician RVU payment. And then there's a multiple factor around a geographic conversion factor. So it's more expensive to practice in the Northeast and the West, and it's less expensive to practice in the Midwest and the South. So those have conversion factors for your geographic location. And then Medicare multiplies that by a dollar amount. So in 2025, it was $32.36. Now, the only difference between Medicare and other payers, whether it be Anthem or UHC or whatever, is those commercial payers have a higher conversion factor than Medicare does. So whenever you're a private practice doctor and you proudly look me in the eye and you say, I don't get paid on RVUs, I get paid on dollars. Well, the dollars that you're paid by the insurance company are determined by this RVU system that is running in the background. So yes, every physician in the country gets paid on the RVU system, whether you're hospital employed or you're in private practice. The only difference is in private practice, you don't know the RVU conversion factor because you're just dealing in the dollars that you've negotiated with the health system around what your conversion factor is going to be. Next slide. So Each procedure has something called a CPT code, or common procedural terminology. For example, a lumbar epidural steroid injection is 62323. So for that, the total RVU amount is 7.74. So if I'm working in a physician office, it's 7.74, which has the physician work component, which is 1.8, and it has the non-facility office, which is 5.36, and then the malpractice component. So that total RVU amount, 7.74, is multiplied by the conversion factor, which in 2025 was $32.36. And that gives you $232.64 if I do that procedure in my office. Now, I've got to buy the drugs, buy the kit, pay the staff, turn on the lights, malpractice, everything goes into that. So I've got to pay everything. And the last person who gets paid out of that is you. So you're running a small business. Next slide. So that conversion factor is negotiated. For CMS, it's not. They just tell you what it's going to be. Medicaid is anywhere between 0.65 to 0.98 of that, depending on which system you're in. Other insurances have different conversion factor amounts. But how do hospitals set their charges? Well, you're allowed to charge 3 times the Medicare allowable. So if Medicare allows $1,000 for a procedure, then you can charge anybody up to $3,000 for that procedure. So what does a hospital do? They always charge the maximum amount. Why? Well, because depending on their negotiated rate, Medicare is going to pay $1,000, but Anthem might pay $1,800, and UHC might pay $2,200, and Blue Cross Blue Shield might pay $2,700. They would never want to charge less than what somebody was willing to pay. So you always pay the max. They always charge the maximum amount. The only person who pays the maximum amount in the United States is, roll the drums, please. That's right, self-pay patients, people with no insurance. They're the only ones who have to pay the entire amount out of pocket, although there is some negotiation that usually happens. So whenever you're talking to a CFO, whenever you're joining a system, and they say, we only get paid 30% of our charges, we can barely afford to pay you this salary, your answer should be, yeah, that's exactly right. You only get paid 30% of your charges because the Medicare allowable is 3 times that. The real question is your collection rate 100% of what you expect, what you negotiated with your payers? That's the real payment that you're looking for. If I negotiated with Anthem to pay $2,700 for this procedure, am I getting $2,700? And sometimes they try to cheat you. As a matter of fact, a lot of times they try to cheat you. So you want your collection rate to be 100% of what your negotiated rate was. Hope that makes sense. Next slide. Now, here's a little caveat. So you take that CPT code, the transforaminal epidural. In the office, there's the $282.64 that I just showed you how you got there. That's the Medicare conversion rate times the RVU amount. But if I do that procedure in a facility, I only get the physician RVU amount, the 1.8 times the conversion factor. Now, ASCs and hospitals, HOPDs, get paid on a different scale. It's quite different. So if I get $282 for the epidural in the office, the ASC facility will get $322 plus the $110 that I made for $432. And if I do that same procedure in the hospital gets a $634 facility charge plus the $110 professional fee, which is $746.86 for doing the same epidural. You may say, why in the world would anybody want to pay 3 times as much, 4 times as much to do a procedure in the hospital as in a physician office? Well, nothing is done by accident. The government is sending you a message. This started in 2003, and what the government was saying was, get out of private practice and go join a group, because as you consolidate physicians into hospital systems and you consolidate hospital systems into larger hospital systems, it's fewer people that they have to negotiate with, and it moves things towards a more manageable payer system. So keep that in mind. ASCs are in between HOPDs, and offices are the lowest. Many of you will go into practices where you work in an office to do your evaluation and management, and you'll do your procedures in an ASC from your injections to your larger procedures. And that is a financial model that is viable. Next slide, please. So this is some proprietary information that really costs thousands of dollars. You have to join the American Medical Group Association. So if nothing else, this was worth the price of admission for tonight, just to get this type of information. And I would encourage you to take this to heart. So the total compensation at the median, the 50th percentile across the country for private practice paying is $494,488. You see the median there. So whenever you negotiate with a CEO of a company, or a CEO of a hospital rather, or a CEO of a large medical group, or a person who owns a large practice, somewhere along the line, they will be looking at these compensation tables. And so there's something called fair value. They cannot pay you more than fair value, but they will often lie to you about what fair value is. So know that the median is about 500,000. The 75th percentile in total comp, that's everything that you make, is about 603,000, and then the 90th percentile is 825,000. So you're negotiating on basically three things: base comp, work RVU, what you're going to pay per work RVU, and then the number of RVUs that you had to get before they start paying you some degree of a bonus. So what does that mean? They'll have a base amount of RVUs that they expect for the base comp, and if you go over that base RVU amount, they will pay you $1 per RVU over that amount, up to and including a certain amount. So we'll talk about the way they can mess you over with some of that. So median is $494,488. Median dollar per RVU last year was $78.88. It's actually going down. It's now $72. I just haven't updated the slide because I haven't gotten the complete updated tables yet. And the median amount of RVUs is about 6,300. That means that the average practice is going to pay 6,300. They're going to pay you about 350. They're going to put you in a bonus range above 6,300, and you're going to get around $70 per RVU in that. That's not a bad deal. So you'll go to a meeting and you'll say, my friend is getting $85 an RVU. There's actually a practice in the state of Kentucky that's paying $90 an RVU. And you come back from that meeting and you go, this guy's getting $98 an RVU. I want to make that. Well, the reason why they're paying $90 an RVU is because it's in a small rural area, nice hospital, but in a very small rural area, it's hard to attract people. So they have to do certain things. So if you're winning on one thing, you can't win on all of them simultaneously. So you might have a lower RVU target and a lower base salary, but if you have unlimited ability to make dollars and your dollar per RVU amount is fine, you can make that up in volume. So next slide. All right, so let's go through a scenario. This is an actual scenario. All of these are from an amalgamation. I've looked at probably 40 or 50 fellow contracts over the last 20 years. And so this is some of the things to watch out for. You're offered $350 for a 5,500 RVU base target and $65 an RVU. If in year one, you generate 8,500 RVUs, which I've calculated, that's actually a pretty decent amount for a relatively busy fellow right out of practice. That's about 800 new patients, and with the procedures that you'll generate out of those 800 new patients and the follow-ups, that's about 8,500 RVUs. And you can probably get up to 10,000 pretty quickly. And then it's up to you, 12, 13, 14,000 if you really want to be busy, 16, 17, 18,000 if you're insane, keep it at 10,000 if you want to have a nice balance. So then you would have 195,000 in bonus. So that's the 8,500 minus the 5,500. So 3,000 times $65 gives you 195,000 in bonus, plus your base salary for a total comp of 545. That would put you above the median salary in total comp. So ways that the CFO can play games. Your target RVUs are 5,500, but they say, we won't bonus you till you get to 6,000. And you say, well, okay. And they say, well, because we've got to recoup our cost on you. Well, that costs you $32,500. That's a crap thing. Tax, an arbitrary number. Hey, we can't let you go over 10,000 RVUs because we want to have good quality. So here's the thing. They know that in year 4 or 5, as your practice matures, it's going to generate 10 or 11,000 RVUs without you even trying. So you will cap out in April and be working essentially for free in May and June if they have a cap. That's a horrible thing for you to agree to. Declining reimbursement above the cap. This makes no sense from an operations standpoint. because all of your cost is in the lower range of the RVU amount. Once you get above a certain percentage, 60 or 70%, everything above that is actually profit for the health system. So to pay you less as their costs go down doesn't make sense. Never agree to that. Other things to watch for. Facilities that support your work. Hey, you know, we've got that unused space in the cath lab we could let you work in. No. Cath lab people never move at the pace you want to move at. Having control over staffing. You want to have a finance or administrative person who understands the business that you're in. So being a pain physician, the guy who trained me said, it's like picking up nickels. No individual nickel is all that profitable, but if you learn to do it efficiently, picking up nickels can be a good business, right? So then there's the CEO doing you a favor. I'll come back to that if we have time. Office based. So there will be some discussion if you're in an office based or you're joining a practice group where they do their procedures in the office around overhead collections and net revenue. Here's the things to watch for. People can play shell games with overhead collections and net revenue. So you can oftentimes never know what overhead really is. So there are practices out there, hate to break this to you, that don't mind bringing you on, screwing you over, and not really paying you what you're worth. So you pull up in your Prius that you've been driving since you were a resident, and you notice that the guy who owns the practice keeps pulling a Jaguar out, and you say, man, he keeps telling me that we don't have enough to bonus me, but somehow there's always this extra cash around for him to do well. So whenever you own the LLC, there's a lot of ways to hide overhead in furniture, in distributions to the owner of the LLC that are difficult to track. So will you ever really know what the collections are, or what the net revenue really is? Will you ever be part of the ownership structure? If you're not in private practice, you're an employee. So just because you're not working for a hospital doesn't mean you're in private practice. If you're an employee and being paid a salary by somebody else, it's really the same as being in the hospital. You're just working for an individual. Now, if a group is bigger than 3 or 4, they've usually figured out how to equitably distribute revenues, and it usually works pretty well. So 20 years ago, there were a lot of single physician practices, 2 physician practices, and those were really easy for new people to get messed over as they join. But now, if you've gotten to 3 or 4, they've usually figured out how not to eat each other alive in that process. So here's a scenario. $225 base, you pay 50% overhead on your collections. Bonus in year 1 is 30% of collections. Year 2 at 35% of collections. Year 3 is 40% of collections. Year 4 it's 45% of collections. A partner in the group makes $570 in year 2 of the plan, but they won't tell you what your net collections are because they say, well, it varies. How can you figure it out? Go to the next slide. Okay, so we know that in year 2, comp is 35% of total collections. So then we can determine net collections by simple algebra, right? So they're paying you $345 in bonus. That's 35%. The 65% is just the algebraic sum of that, plus your base salary of $225, which gives $1.2 million. They're not going to give you a base salary over and above what your net collections are. That means that I call this guy Dr. Love You, man. I love you. Love you. We just don't have enough to distribute more bonus than this. That means Dr. Love You, man, who owns the practice, is taking home $640,000 of your dollars in year 2. Now, maybe that's because they were floating you through the lean years. A lot of times practices are busy enough that they're in the black on you in 6 months. That's how you efficiently bring on a new associate, is you bring them on with enough volume to make things doable. But you've got to be able to figure out, get to the net collections or your net revenue if they don't show it to you. And by the way, it's a big sign if they don't show you what those things are. Next slide. So, summary, don't get too tied up in the first job. It's unlikely to be your long-term job. People change jobs 3 to 5 times in a career. You have a lot of things to get stabilized in your first year out. Your practice patterns, cementing your procedural skills, learning patient management. Observe the business side over 2 to 5 years, and then make decisions about your future based on what you're learning. And then you can make more educated decisions. I'm not saying allow yourself to get messed over. It's just you don't know what you don't know, and it's just like investing. When you first get out, it's likely that you will not make wise investment decisions either. Um, Tina mentioned something about hiring good people to look over things. My experience is most contracts are boilerplate. So the things you need to look for are the net revenue collections and how the bonuses are going to be distributed, or the base salary, the dollar per RVU and the RVU amount. Things like restrictive covenants, those sorts of things are important. But most contracts are boilerplate. Most hospital systems will absolutely not budge on their contract because they have to be approved and signed. So they have a whole group of folks that have signed onto these contracts. So typically there's very little wiggle room in a lot of contracts that you will sign. Before assuming that you're being taken advantage of, try to determine why someone is doing what they're doing. Once you find out the answer, there may be a legitimate reason. And if there's a legitimate reason, try to find out what that is. Otherwise, it could be greed or ill intent. And whenever it's that, you got to walk. The guy who just rejoined us, he was a fellow, great guy, wanted to get back into a hospital-based practice after an experience where, hey, I learned a lot of things, in my first job out in private practice. Second guy, exact same scenario. So there's something to be said for a well-run multi-specialty group or hospital-based practice where you have control over your environment. It's not always that the private practice is the best environment. There are wonderful hospital-based and large multi-specialty group environments out there to join where you don't have to run the practice, but you can also be very, very busy and very, very active. So with that, I thank you for listening and happy to answer any questions.
All right, well, I'd like to thank our speakers, both Ms. Rivenbank and Dr. Greider tonight. I want to point out to all of our people who are listening in that this is our question and answer opportunity. And so you can use the chat function in the GoToWebinar to write in questions for our panelists here. I'd like to start out with a first question to Dr. Greider, and that would be to define what RUC is and how do you get on to RUC? Who are these people that are doing the negotiation for our specialty writ large?
So RUC is one thing. So RUC is a local coverage determinant group that actually in a local area, so there's something called an LCD, local coverage determinant, where you can go and negotiate the local Medicare environment for like a 2-state region or a 3-state region. So they're always taking comments. They're always open to input and that sort of thing. A lot of times it's just if you want to be involved in it. The American Society of Interventional Pain Physicians has an amazing ability to put pain physicians on most of the local MAC, the Medicare advisory committees who do the RUC. What I was talking about was the RVU committee, which is on a national level. So each medical society, so the American Society of Anesthesiologists has 6 anesthesiologists and 4 pain physicians and 1 critical care physician that descends on these. So there's 9 physicians that go and they negotiate the RVU rates. The American College of Orthopedic Surgeons has like 14. So those are actually picked by the major specialty societies that are part of the AMA colleges that do that. And so they're the ones who negotiate that. Richard Rosenquist, who many of you may know, is the lead pain negotiator for interventional pain as nominated from the American Society of Regional Anesthesia.
And Dan, do you have a question for Tina here?
Yeah, Tina, one thing that was touched upon was partnership tracks and buying structures. What do you think, I guess, is a fair timeline where you can start having these types of conversations when you can become a partner and when you can start to buy in for pain practices?
So I think that varies a little bit depending on the organization, as I gave the 2 examples earlier of a well-footed practice where they've had numerous physician associates. I think those folks are more flexible and confident in giving a finite partnership track, whereas a practice that's held by, say, a single physician who started that practice with their own blood, sweat, and tears, that might be a little scarier to them. It's kind of like getting married without dating. So how long is long enough to date someone before you feel confident enough to marry them? That's my analogy. I think that the take-home message in that conversation really is less about the date in the future and more about how am I going to be evaluated for being a reasonable partner option? What kinds of metrics do you expect me to meet? What does it look like if I'm being a successful physician associate? And what, how would the practice be valued? Perhaps you might could even go that far and say the practice is going to be valued at this date and time, and the partnership structure or the equity that is transferred over will be done on X schedule or some metric thereof. But again, I think it's hard when you first meet someone and first even work with them for 3, 6, 9 months to know if that's going to be a great situation long term.
All right, the next question I'm going to throw out to Dr. Greider. These examples that you gave, are they applicable to PM&R as well, or are they equivalent? Or can you shed some light on whether or not those data would just be for pain physicians who have specialty training as anesthesiologists? Please comment on that.
Sure. So just in the interest of time, there's actually a separate MGMA slide around PM&R pain management. And that's a little bit of old thinking because there was a time where PM&R physicians, you could hire them a little cheaper and they would have even a little bit more skill set because they can do EMG. So there are other revenue streams that they could bring to the practice. Those days are essentially ending, and MGMA, those numbers are getting closer and closer together, although they still have a separate number for PM&R. What I basically tell anyone who's in PM&R is do not accept a lower number because you're a PM&R physician. There's no basis behind it. There's no reason for it. No CFO can justify it because the negotiated amount from Medicare or from the commercial payer is blind to what your specialty is. So their reimbursement is the same. Your reimbursement should all be the same, and it'll even itself out. It's even evening out as we year by year they get closer and closer, and especially as PM&R becomes more prevalent within our specialty.
Yep. And I think one thing to understand is that if you're in a pain practice, you're going to be doing well or better if you're in a procedure-based practice as opposed to a office-based practice or where you just prescribe medication, prescribe physical therapy, and really don't do procedures. I think that's where the difference is. This particular question's for Tina. Someone asked, is it possible to open up a private practice setup under a hospital so that you can operate on your own, but still then charge the hospital higher hospital, or does that run afoul of Stark laws?
No, that actually is very possible. I've put together several opportunities exactly like that. That's generally done through what's called a professional service agreement. And the professional service agreement is simply a contract that allows one provider or facility to bill for another provider. So I've even helped orchestrate professional service agreements from one pain practice to another when there were issues with networks being closed and new practices not being able to gain participation in, say, a Blue Cross network or an Aetna network that might be significant. I've put those arrangements together with between a pain practice and a neurosurgical practice, because the neurosurgical practice in the area had much better commercial payer rates, and all of those things are done through that vehicle, which is a professional service agreement. So yes, that's an option.
Yeah, Dan, why don't you ask the next question, please?
Sure. I'll give this to Dr. Greider. So someone asked, can you speak on sign-on bonuses and what is a reasonable amount for a sign-on bonus?
So a reasonable amount for a sign-on bonus is, boy, that can be all over the place, right? So there really is no reasonable amount. So how much to understand? Let's back up. Anything that you win in one place is going to be a loss in another, because a practice or a healthcare system only has so much that they can put towards this compensation package. So you may negotiate a lower upfront salary and a lower RVU target that goes with it, but a higher dollar per RVU. And people may go, why did you take that low salary? Because you know that in year 2 or 3, a base salary is not going to matter to you at all, because you're going to be busy enough to blow through that. So that bonus comp that you're going to get, they may give you a $50,000 sign-on bonus, but you may not be getting the maximum dollar per RVU amount that you would have gotten. So you might get $50,000 up front, and they're smart like thieves, right? That $50,000 upfront investment, they shaved $5 per RVU off of your amount. You were happy to get it because you're cash poor, but you ended up losing $400,000 over a 5-year period that you could have had in bonus. So just be thinking about all those things. Nothing is free. No one loves you except for your mom and your dad. So the sign-on bonus is not anything other than just something to get your signature on the line, and it is coming from somewhere. You are paying for it somewhere. So just figure out where that is, and can you live with it?
Good advice.
Sorry, that's a pessimistic view. Sorry.
Good advice.
Yeah, and one last question here to Tina. If you're looking to sign up with a private practice created by the one single physician who started it, what are those absolute necessary questions to ask, or at least get the answers to? And how do you know that these numbers are real, that they're going to be spouting off or sending you in the mail?
Yeah, so it's not typically the norm that a private practice is going to open all of their books to you. They should know exactly what their annual revenue is. They should know what their overhead is. Now, overhead is a moving target. You know, as they add providers, their overhead goes up until that provider gets on to where they're producing at a level that's covering their expenses plus the fixed overhead associated. So a moving overhead is not necessarily a bad thing. They're probably just being realistic with you. They should have very finite information, definite information around annual revenue. If you're going to work in a practice, that practice should definitely open up the reporting for you on what you produced, what you collected, what was the expected collections, as Dr. Greider alluded to, and you know, based on their contractual fee schedules, and how your productivity was collected as expected. If they're billing on the 300% of Medicare and you produce $100,000 in a month, and a third of that should be $33,000, yet they only collect $20,000 on you, then perhaps there's a revenue cycle management issue that also would need to be considered, that can very definitely impact what you get paid if your compensation is tied to collections versus RVUs.
All right, I'd like to thank our panelists tonight, Dr. Greider and Ms. Riverbank, for excellent presentation. I want to remind all of our listeners that we have several additional educational opportunities coming in the near future. The first of which is the International Society of Pain and Neuroscience meeting. It is being held in London next month. Following that, in October, we will have our second in our series of webinars for this Fellowship in Young Innovators Committee. That one is going to be on fluoroanatomy and radiation safety. And following that, later on in the year, we'll have an additional one on MRI interpretation. And then finally, remember that our Aspen annual meeting is going to be once again in July in Miami. and you'll want to reserve some time in your calendar to make sure that you can meet that. So with that, I want to thank Dr. Pak for co-moderating with me tonight. Once again, a great thank you to our speakers and to everybody who signed in. Thank you for your time and attention, and everyone have a great week. Thank you.